We are going to talk about pericarditis. Here are your objectives related to pericarditis.
Frequently see endocarditis and pericarditis discussed together. But as you can see, I didn't do that. And that's because I don't want to just teach you about different diseases that can affect the body. I want you to see the body for what it is, an interconnected network where dysfunction or a pathophysiology in one organ system can lead to multiple pathophysiologies or multiple organ dysfunctions. Now, endocarditis, remember that's going to be your inflammation of your inner layer. That can cause a thrombus formation, which can break off and lead to an emboli and cause a myocardial infarction. Well, pericarditis is going to be a complication of myocardial infarction. And I want you to be able to see the evolution of these different diseases and their connection between each other. That's why I separated them. Now, remember, our heart lays in the pericardial sac, right? And remember, this sac is going to contain two layers. You're going to have your parietal layer, which is going to be your outer layer. That's going to be your more rigid layer. And then you're going to have your visceral layer. That's going to be the inner layer. And remember, serous fluid or visceral fluid is going to be separating these two layers. Now, with pericarditis, you are going to have inflammation between these two layers. And that's going to result in a restrictive fluid buildup in your pericardial sac.
Causes of acute pericarditis can be related to infectious organisms such as viruses, fungi, bacteria, and it can involve toxins such as toxoplasmosis or Lyme disease. And non infectious causes can occur post myocardial infarction, that's called post myocardial infarction syndrome or Dressler syndrome. You can also develop pericarditis from renal failure, neoplasms, trauma, radiation, a dissecting aortic aneurysm, autoimmune causes such as rheumatic fever, lupus, rheumatoid arthritis, systemic sclerosis, and other connective tissue diseases. And sometimes it can just be idiopathic in nature, meaning we don't know what causes it. Clinical manifestations of pericarditis can be somewhat similar to an acute myocardial infarction, which can make these two hard to distinguish from one another. And with acute pericarditis, you're going to have that progressive sharp chest pain. It's going to worsen during inspiration and when laying flat. What is going to help it is sitting up. And remember, with an acute myocardial infarction, there are no relieving factors, and nothing's necessarily going to make it worse, such as breathing in. So that's kind of one way to kind of differentiate the two. And like a myocardial infarction, the pain may radiate. A patient is also going to have dyspnea. You may hear a pericardial friction rub. Remember, you have that inflammation, so you have all this stuff rubbing together. A patient may present with a low-grade fever. And when we go to diagnose acute pericarditis, we are going to use a combination of symptoms that the patient is experiencing, such as the low-grade fever, we hear a pericardial friction rub, a patient has chest pain that is going to worsen when laying down. We can use imaging such as a CT, MRI, or an echo. And we're going to view various labs to see our basic inflammatory markers are going to be elevated as they are in cases of inflammation. Dressler syndrome is a type of immune-mediated pericarditis that is going to occur following injury to the myocardium, such as with a myocardial infarction. And what's happening is that you have an infarction And your body's immune system is going to overreact. And it is going to release antigens that are going to trigger the immune system to produce autoantibodies and inflammatory responses, leading to that pericarditis. It's very similar to your SIRS, your ARDS. So you're going to release these antibodies, and it's going to lead to inflammation of your pericardium. So your symptoms are going to be the same. Your diagnostics will be the same. Treatments will be the same. It's just the main difference is the etiology is just going to be the body is doing it. And this is usually going to appear anywhere from 3 to 6 weeks after an MI, and it's pretty rare. I think 3 to 5 out of every 100 or so patients will develop Dressler syndrome. But important thing to know here is post-myocardial infarction, and it is just your body overreacting.
Treatment for pericarditis should be targeted towards treating the underlying cause. Reducing inflammation and supporting the body through this disease process. So let's say the underlying cause is bacterial. We would administer IV antibiotics. Now, sometimes we cannot target that underlying cause. So now we have to focus on symptom and sign reduction as well as supporting the body. Now, we may administer anti-inflammatory agents such as NSAIDs, one of the few times you'll actually see this. You may also see colchicine given or steroids to reduce the inflammation.
Nursing interventions related to a patient with pericarditis is going to be related to meticulous assessment. Remember, their chest pain is going to generally be substernal. It's going to be worse on inspiration. And it is going to decrease when the patient leans forward and gets worse when they lay flat. As the nurse, you want to auscultate for that pericardial friction rub. You want to assist the patient in a comfortable position to where they feel as though they can breathe and their chest is not on fire. You want to provide anti-inflammatory agents as prescribed, and you want to educate the patients that these can take 24 to 48 hours to work. And you want to avoid administering aspirin and other anticoagulants, unlike how you would do with an acute myocardial infarction. And that's because they can actually increase the risk of a patient developing cardiac tamponade, which is a life-threatening medical emergency that can occur following pericarditis or a pericardial effusion. And I'll discuss that in obstructive shock. And it's important to know how to auscultate the blood pressure to detect for paradoxical blood pressure. And that's going to be a classic sign of pericarditis that has led to cardiac tamponade. Chronic obstructive pericarditis is going to be very similar to the other chronic diseases we've talked about, such as CKD, liver cirrhosis. What is going to happen is that pericardial sac is going to lose its elasticity because over time there is going to be scar tissue forming, which is going to become fibrotic and non-functional. And causes are very similar to that of acute pericarditis. It can be idiopathic, infectious. It can result from connective tissue disorders such as lupus and others. And with constrictive pericarditis, what's happening is you're going to result in reduced cardiac output because what's happening is that thickened pericardium is going to prevent the heart from expanding normally during diastole, which is the resting phase of the heart. And this is going to lead to increased pressures in the heart chambers and ultimately reduce cardiac output because it's going to affect that preload in right side of the heart. So you can expect symptoms similar to that of cardiac tamponade, regular pericarditis, and right ventricular failure. You may have fluid overload like ascites, JVD. You may see the Kussmaul sign. You can see signs of fluid overload, right? Peripheral edema, anasarca. You may have that pericardial knock or that pericardial friction rub. You may have pulsus paradoxus. And ultimately, the treatment for constrictive pericarditis is going to be a pericardectomy. And that is because it is constricting. Unlike with acute pericarditis, which is generally non constricting.
Now, you may be thinking that there's quite a few similarities between the clinical presentation of a patient in acute pericarditis and one with an acute STEMI. I mean, they both have chest pain, they both have ST elevation, so it's the same, right? Absolutely not. And once you're familiar with both conditions, unlike when we were doing our trauma exercise, and some of you thought that the patient with the pericarditis was having an ST elevation infarct, but no. There's easy ways to distinguish the two once you're familiar with both conditions. For one, chest pain with acute pericarditis is going to be worse when laying down, and it is also going to be worse when breathing in. Now, your chest pain in your acute STEMI is not going to present that way. Laying down isn't going to worsen it, and breathing in doesn't. So, they both have ST elevation, so how can I tell? Well, with acute pericarditis, it's going to be widespread distribution. There's going to be ST elevation like everywhere. Maybe not everywhere, but it's going to be widespread. And your ST elevation will not be as prominent. Generally, if you get out your calibers and measure it, they're going to be less than 5 millimeters. And you're not going to have any reciprocal changes. You won't have ST depression in your reciprocal leads. And you really won't see T wave inversion, because remember, that is an indicator of ischemia. Now, with your acute STEMI, the ST elevation needs to be in 2 consecutive leads. So you need to see them back to back. It's not going to be widespread, because when you have an infarct, remember your coronary arteries, what's perfusing the heart, they go to certain parts of the heart. You remember they branch off. So you're not going to have ST elevation everywhere. No. And they're generally going to be much higher, greater than 5 millimeters. Now, remember, with a STEMI, you're going to have interruption to your electrical conductivity of the heart. So, of course, you're going to see ST depression in the reciprocal leads. And you will see some T wave inversion. So, as you can see, on the surface, it seems like they're very similar, but they're really not. And I bet if we were to do that trauma exercise again after this lecture, you would be able to easily tell by the symptoms that the patient was experiencing pericarditis. But I'm glad you thought acute MI at first. I am.